Hello everyone. We'll take a few minutes talk something about the second line treatment of ITP. And when a patient failed to respond to first line treatment, corticosteroids or IVIG, or get a very quick relapse, we have to start a second line treatment. And there are many second line treatment. According to the guidelines of the International Working Group of ITP and also guidelines of ASH, the choice sequences of second line treatment is alphabetic order. In other words, they don't know which one is the best, which one is the second, so they made it alphabetic. However, in the recent published Chinese guidelines, we give first choice of second line, second choice of second line, and third choice of second line, because we do have clinical evidence on the first choice drugs, for example, the TPO receptor agonist, and we do have many evidence on rituximab, and also we have some evidence on splenomegaly. Therefore, in our new guidelines, we recommend the first choice of second line is TPO receptor agonist, and the second choice is rituximab. The third choice is splenomegaly, and the fourth and others are still in alphabetic order. So we first take TPO receptor agonist. Nowadays, there are 3 or 4 drugs launched in the world. In China, only 2 launched. The first one is recombinant human thrombopoietin. The second one is L-thrombopark. These 2 drugs are available in China, and still other 2 available in many other countries. For example, the rimipostim, which is launched in US and European, and also recently launched the 4th TPO receptor agonist called avatrombopag. These drugs might be available in the near future in China. And this group of TPO receptor agonists have a very high response rate, which close to 70 to 90%. And the limitation of this drug is that they depend on individualized maintenance treatment. In other words, you cannot stop them. If you stop the treatment, the thrombocytopenia will return. And the second limitation of these drugs is there might be a risk of thrombosis. When the platelet count goes very high and very fast, especially in the very old patient, they might have thrombosis. And the third limitation of this drug is that they are still pretty expensive. So these drugs you can use, but there are limitations. The first choice is TPO receptor agonist. And the third choice of second line treatment, the second one is rituximab. Rituximab, it has a response rate of closely to 50%, and the long-time sustained response close to 20%. This is very similar to splenomegaly. However, it was a drug, so-called the internal medicine splenomegaly. And these drugs also have limitations. The first limitation is that it might have infection after treatment. So you have to replace or give the patient IVIG timely to prevent infection. And the second limitation of rituximab is the long-term response is not very high. And the third choice of second treatment is splenomegaly. Splenomegaly, the response rate is about 70%. Long-term response rate is about 30%, therefore, which is very close to rituximab. However, it also has limitation. The first limitation is that you have to remove your spleen, remove an organ. In Chinese medicine, spleen and stomach, they are very good friends. If you take one of them away, the other one will not be glad. So that's first point. The second point is an operation, it has a risk of complications, for example, infection, thrombosis, and many others. Despite the lower risk, however, in ordinary operation, the risk of death of splenectomy is 1%. And if you use a microscope operation, the risk of death is 0.2%. So splenectomy, you have to pay attention, and you have to talk very carefully to your patient and discuss thoroughly with them. Many other second-line treatment are still not many evidence available, so I will not take many time on that. You have to reference on the recent published guidelines of Chinese and ASH and International Working Group. Thank you.